All right, let's start again. This is what we are going to talk about, basic of echocardiography. The most important thing in basic of echocardiography is we learn the art of echo. And the beauty of learning echo today lies in not the freshness of atmosphere, it lies in the freshness of your thoughts and feelings, how wish you want to learn this particular program. When we talk of echo, we talk of understanding the basic images. And what are the benefits of echo? Absolutely non-invasive, no side effects, no trauma, cost effective, can be done n number of times. It provides a unique window to the heart and it gives you structural, functional, and hemodynamic evaluation about your heart. Points of talk would be indications, who should do it, type of transducer, view and importance, wall motion abnormalities, and hemodynamic evaluations. What is the understanding of basic images is? If you have to do an echocardiography, any indication to look for a heart is echocardiography. So much so, even a gynecologist want to learn echocardiography because they want to look at the heart of a patient if they're present in the night for cardiac evaluations with breathlessness. We talk of M mode, the first one in echocardiography. And in this M mode, we have a very important definition, which is known as leading edge to leading edge, trailing edge to trailing edge. What do you mean by leading edge? Are you able to see the image now? Anybody?
Yes, sir.
Okay,
Yes, sir.
all right. So if I keep my transducer of left side of this image over here, this becomes leading edge and this becomes trailing edge. So every echo has got a finite diameter, finite width. If the transducer kept on top of this image is this is a leading edge and this is the trailing edge of this image. If this is another image, this becomes the leading edge and this becomes the trailing edge. If I'm doing an M mode evaluations, I'm talking of leading edge to leading edge. If I'm doing a 2D measurements, I'm talking for trailing edge to leading edge. Are you clear? So this is what is important for leading edge and trailing edge. Now look at this window over here. This is RV free wall, or let's say this septum. If I'm talking of this septum over here, and this becomes the leading edge of the septum, and this becomes leading edge of this septum over here. So it has got a very fine thickness over here. This is endocardium. I'm not bothered about endocardium. So look at this small thickness over here. So this becomes leading edge and this becomes trailing edge. And that's how, if I'm doing my M mode measurements from here, this is the leading edge of the LA. This is the trailing edge of the LA. If I'm doing 2 dimensions echo, this will become trailing edge to leading edge, which will come back again and again. Now, classical image. Look, this is M mode. This is 2 dimensions echo. If I have to measure my LV cavity, I'll measure from this place to this place, trailing edge to leading edge. Trailing edge to leading edge. Otherwise, I'll measure from this point to this point. Next word comes resolution. What is resolution? Is the ability to identify 2 different objects lying close to each other. How do I say these words? You stand on a highway. A car is coming from a far distance. The 2 lights looks like a blob. When they come closer to you, they start looking as 2 separate lights. And where they're standing right in front of you, you can say, what is the size of the light is? What is the difference between these 2 lights is? What is the texture of these 2 lights? So the car, when it's standing close to you, it is the highest resolution. And when it's away from you, that's the poorest resolution. Second come words penetration. What is penetration? Penetration is depth. A neonate will not need a depth because his heart is closer to chest. Whereas the adult persons, the heart lies almost 15 centimeter inside the chest. So it is known as penetration. Now, based on resolution, based on penetration, we come on the type of a transducer we use. Closer structure, they are best utilized by high frequency transducer, but they have a poor penetrations. So higher the frequency, poor penetration, good definition of a cardiac structure for poor Doppler studies. Lower frequency means 2.5, higher frequency means 10. 2.5 frequency transducer, they have a very good penetrations. Poor near resolutions, but good Doppler studies. So hence, they are used for adult population. This is used for neonatal populations. And once we have these transducer, now they were linear phase array transducers. Now we have broadband linear phase array transducer, which is known as harmonic imaging. What does it do? It sends an impulse beat at 2 megahertz, receive back up to 4 megahertz. How does it do? The near structure, they're scanned by 4 megahertz, and the farther structure scanned by 2 megahertz. And this is what our transducer utilized as on today in clinical practice. So whatever the frequency is, they almost double the frequency, and they called as broadband linear phase array transducers. Then size of the footprint is very important. A pediatrics or neonatal transducer will have a very small footprint. Footprint means the part of the transducer which touches the chest wall of a patient. That has to be very small. In contrast, that is bigger in size of adult populations. And I've seen many people using abdominal transducer doing an echocardiography because the transducer cannot insinuate in between intercostal spaces. And then just a historical PDOF crystal transducer. This is pulse Doppler flow crystal transducer is. Then what are the types of transducer we use?
Lost your voice.
So we lost your voice.
It has come back again?
Yes, sir.
Yes.
This is internet glitches, which will happen now because every system is on as on today. Because everybody will be using internets. Anyway, let's move on. So this is a historical PDOF crystal transducer. Pulse emitting Doppler flow. That's a PDOF crystal transducer. And this is one we used when we never had a continuous wave Doppler. This was a single crystal transducer was used for calculating aortic flow velocities. Then what kind of a transducer we have as on today? We started with single oscillating crystal transducer, then rotating transducer, then annular phase array transducer, linear phase array transducer. And this is what is the most important thing is linear broadband phase array transducer. Anything less than that, they are trying to sell you obsolete systems. So once you buy, you should buy always harmonic imaging transducer. And you should try to put your foot down nowadays for multi-planar broadband crystal transducers. And finally, 3-dimensional transducer. This is linear. And look at this. This is a linear phase array transducer it is. Why I'm saying, look at these images very carefully. What is the difference in these images? I'll play it again for you. Look, apex is very clearly seen in this image. Apex is not seen clearly in this image. This is a linear broadband phase array transducer over here, harmonics. This is fundamental transducer. What is doing? It is at a 2 megahertz frequency is imaging the base of the heart. In 4 megahertz transducer, it's imaging the apex of the heart. And look, apex is very clearly seen in this particular 4 megahertz transducer. Now look at the apex. The apex is not seen over here. And that's what makes a difference in linear broadband phase array transducers. This is 3 dimensions echocardiography, which we can use whenever it's required, especially for structural heart disease, holes and shunts. Not at your level to talk about all these things, but you should know what is 3 dimensions echo transducer. Now, the most important thing for you is to remember what is long axis view, what is short axis view, what is a 4-chamber plane view is. Long axis view is when we are cutting a heart from apex to the right shoulder at 3 o'clock positions. So this is long axis view. When we cut the heart perpendicular in a short axis, this is short axis view. And when we keep a transducer at the apex, we make 4-chamber plane. So remember long axis, short axis, and 4-chamber frontal planes. This is again pictorial diagram. This is long axis view. This is short axis view. And this is 4-chamber plane. How do you cut that heart? Suppose the long axis view is like this. What is cutting? It will cut LV, LA, some part of RV, and then the aorta. If it's cutting a short axis view, it depends what place is cutting. If it's cutting at the level of mid LV cavity, so you'll have papillary muscles and LV cavity. If it's at the level of apex, it will be only apex. Or it could be at the level of short axis view at aorta. So I'll show you short axis view at the aorta. Little difficult, but you'll remember over a period of time. This is index marker of the probe. Every probe has got an index marker, either a groove like this, or we have a light over here in the index marker. Patient normally lies in left lateral decubitus positions. Why? Because with which we bring more of our heart closer to our chest. This is left parasternal window. What is this left parasternal window is? We keep a transducer in left third intercostal space, close to sternum, index marker facing 11 o'clock. Look, there's a watch over here. This is 12, this is 6, this is 9, this is 3. My index marker left third intercostal space, and my index marker is facing 11 o'clock position. And that is known as left parasternal window. And when we do left parasternal window, we start always adult population in the left parasternal window. Then apical regions, subcostal region, suprasternal region, right parasternal regions. So these are windows like left parasternal, apical, subcostal, right parasternal region, and suprasternal regions. Again, in relation to bones of rib cage, left third intercostal space, 1, 2, 3, third intercostal space over here. Close to sternum, index marker at 11 o'clock positions. That is left parasternal window. You go to apex, left fifth intercostal space, index marker at 3 o'clock position, 2 or 3 o'clock positions. And we are as parallel to the heart as possible. Subcostal in the subcostal window. Right parasternal, right second intercostal space, and index marker facing roughly at 1 o'clock position. Suprasternal, index marker at 3 o'clock position. We are right into the suprasternal window. We'll repeat again and again when the things come back again. Now listen, the most important windows are parasternal window. They look very exhaustive. They are not when we start doing it. So there's a plaques view, short axis view, RV, RN flow view, and pulmonic artery flow. Then let's start parasternal long axis view one by one. I said third intercostal space, index marker at 11 o'clock position. What we look is plaques view. We look at RV, RN flow view. We look at parasternal short axis view at aorta, mitral valve, papillary muscle, apex. Now I'm sitting at long axis plane with left third intercostal space, my plaques window. So what do I do? If I'm doing this, I'm going to get a views. Now look at the imaging quality over here. This is a video recording. My patient is in third intercostal space. Index marker at 11 o'clock position. I'm close to sternum. And what do I see? This view over here, this view over here is the same. So you know where is my index marker? How I'm cutting in long axis view. What do I get out this window? This is a touch of a transducer. This is RV free wall. This is RV. This is anterior aortic root. Then this is a cusp of the leaflet. This is posterior aortic root. This is LA cavity. Anterior aortic root is in continuation with interventricular septum. Posterior aortic root is in continuation with AML. And then LA free wall is in continuation with posterior wall. And here is descending aorta. Look at it very carefully how you can put your probe right into the left third intercostal space. What view you get is, this is the particular view is. So LA, LV, aorta, RV on top. Here is a descending aorta. And here is the coronary sinus, would be seen somewhere over here. Now, from plaques window, we go to RVR inflow view. Look how it's going to RVR inflow view. Now he's tilting a footprint towards mediastinum. Very simple movement. So what do you get? As you move your footprints, let your footprints look toward mediastinum. You will get a view. Here is RA, here is RV, and here is a tricuspid valve. Now you can see this movement. Here is RA, here is RV, and here is the coronary sinus drainage of this RA flow view. We are doing the same thing at plaques window only. What does it make importance? We can get a very good tricuspid regurgitation jet from this TR. We are right parallel to this Doppler flow across this. Now we go to short axis view. How do you get a short axis view? Now look, how do we get a short axis view? Correct. Now what does it do? You go back again. Plaques window, rotate 90 degree toward 3 o'clock position. Footprint looking toward aorta. Medius footprint look to the mitral valve, papillary muscles, and finally to the apex. So rotate transducer 90 degree clockwise. Footprint looking toward aorta. Here's the aorta. Here's the tricuspid valve. Here's the papillary muscles. So by cutting, you can look at the papillary muscles and then apex finally. Now look at the movements of the transducers. So what view do you get out of this is, we get aorta in the center, LA, RA, tricuspid valve, RV, RVOT, and pulmonic artery. This is this is shifting his transducer now. Look, it'll show a movement. Now rotate 90 degree. Now footprint towards aorta. And what view you get is, this is what you get in aorta in the center. Left coronary artery, right coronary artery over here, non-coronary cusp, right coronary cusp, left coronary cusp. And pulmonic artery wraps around aorta to give rise to right pulmonic artery and left pulmonic artery. Just behind the aorta is left atrium. Here is the right atrium. Here is the tricuspid valve. Here is the interatrial septum. Then as he moving his transducer back from aorta, now he's moving back from aorta. Now I'll go to aorta. Now I'll come back again. Look at these things. Now, yes. So at this particular point, when you're perpendicular third intercostal space, what do you get it? We get view at papillary muscles level. So this is, sorry, not papillary, mitral valve levels. So this is at mitral valve AML over here, PML over here, and short axis view of the LV cavity. Now we're coming back from aorta towards left hip now. As we come closer towards left hip, we see the muscle, mitral valve will disappear and papillary muscle will start appearing in this particular fashion. And finally, the papillary muscle will disappear and the apex will come. So now I'll go and show you the views. Repeat it again. 90-degree, footprint looking to aorta, short axis view at aorta, then mitral valve, then papillary muscles, and then the apex. 4 views, which you see over here. Now moving from apical parasternal window, let's move towards apical window. Now let's see what the views are. Dr. Aditya, you have to silent your mic, man. Please silent your mic. IT people are not very good people over here. And this is fully recorded. If you'll make a mistake, it'll go to everybody. Second important thing is you're disturbing somebody. I know you're losing your practice, but believe my practice, your practice will multiply many folds once you learn these training programs. Now let's move to apical windows. So where we have moved, we have gone to apical window. And let's see how we are going to apical window is. I moved from third intercostal space to apex. I'm trying to be as parallel to the heart as possible. Counterclockwise rotate, come back to almost 11 o'clock position. Now very interesting phenomena which is trying to show you. Apical window, counterclockwise rotation. So we'll have 2 chamber and then finally 3 chamber. What is trying to show you? If you move your apex, you move your probe from left parasternal window to apical window. So what view you will get? You will get apical 3 chamber view. It's something like Plaque's view. That's what he's trying to do. Look at again. Apex to, sorry, parasternal window to apex window. He'll rotate clockwise. 2 chamber, then finally 3 chamber. But the true apical window is left fifth intercostal space at the anterior axillary line, index marker at 2 to 3 o'clock positions, and what view you get is a 4 chamber view. What is this 4 chamber view is? LV, LA, RV, RA. This is septum, this is lateral wall. This is AML, this is PML, and this is left atrium, this is descending aorta. This is RV, RV free wall, tricuspid wall, and RA. So this is what you get a 4 chamber view. And if this 4 chamber view gives you a lot of information in clinical practice, what information give you? Because we look at walls, septum and lateral wall. Now mitral valve is very much parallel to the blood flow. And tricuspid wall is also parallel to the blood flow. Aorta opens up in 5 chamber view, even that becomes parallel. So lot many hemodynamics are done in apical 4 chamber, 3 chamber and 2 chamber. Now we rotate probe counterclockwise. Look carefully how it's doing it. He has come to apex. Index marker, he's gone to 3 o'clock positions. So you're getting 4 chamber view. Now look is how parallel to the heart is. Counterclockwise rotate, 2 chamber view. Further counterclockwise rotation by 11 o'clock position become 3 chamber view. So we start with apical window at 2 to 3 o'clock positions. We rotate probe so as to make about 1 o'clock and find in 11 o'clock positions. In doing this, in apical window 4-chamber view, what will be doing it? We'll be doing in 4-chamber view, apical window will be looking at septum lateral wall. 2-chamber view will be looking anterior inferior wall, and 3-chamber view will be anterior septum and posterior wall. Look, this view is not different from plaques window. Only thing is it's erect or standing plaques view. And that plaques view was lying down plaques view. Let's go back and see what is that plaques view was. Look, this is lying down plaques view. And what we see, same structure which goes up. We see whole of the LV cavity and the tip is up. Then we call them as 3-chamber. So this is 3-chamber view of a same patient. So this becomes anterior septum. This becomes posterior wall. Here this becomes anterior wall. This becomes inferior wall. And finally comes to subcostal window. We left the index marker at 3 o'clock position. We keep the index marker at 3 o'clock position. Patient's subcostal window at subxiphoid regions. Legs are folded. And when the legs are folded, now it shows you the movements. Almost parallel to the heart, and the index marker now counterclockwise rotations. So what all view we see? We see subcostal window, RV, RA, LV, LA. Once we do a counterclockwise rotation, we see IVC. Suprasternal window, index marker, supraclavicular window at 1 o'clock positions. We are perpendicular. All right. So what all view do you see in suprasternal window? We see ascending aorta. Here is the ascending aorta, arch of aorta, and then descending aorta. Here we see 3 neck vessels, left subclavian, left common carotid, and then innominate vessel. Innominate give rise to right common carotid and right subclavian artery. Last, right venous window. I'm not going to touch at this moment for you, but let's see. Let's write third intercostal space. Index marker 11 to 2 o'clock position. So 2D echocardiography is the backbone of echo. Whatever we do today is all based on 2 dimensions echo. M-mode, Doppler studies, they're all based on M-mode echocardiography. Then magic word, ejection fraction. Believe my word, this is a minuscule picture of any echocardiography as if only we talk of ejection fractions. But how do we calculate ejection fraction? Is always by modified biplane Simpson's method. What does we do? We go to 4-chamber view, calculate the area into length, and the machine divides into small diskettes. Diastole and systole will give you single plane modified ejection fraction. Then we go to four chamber view, two chamber view, diastole and systole. We calculate and then we average them up. We call them as modified Bioquin-Simpson's method. Well, more than 52 for males, more than 52 for females. That is said to be normal. But it is likely to be revised in next 10 years to 57 for males and 58 for females. Wait for some time. Then next come the coronary artery blood supply. How do we look at coronary artery blood supply? The coronary artery, four chamber view is mid basal septum, mid basal inferior wall supplied by RC. Mid basal posterior wall, mid basal lateral wall supplied by circumflex. Rest all is LED. So we have 6 segments. Septum has got apical septum, mid septum, basal septum. Lateral wall has got apical lateral, mid lateral, basal lateral wall. This is 4 chamber view. 2 chamber view has got mid and basal inferior wall, and this is apical inferior wall. This is apical anterior wall and mid and basal anterior walls. So where the papillary muscle attached? They are attached to either lateral wall or medial wall. Then we have a 3 chamber view. Here becomes posterior wall, mid and basal and mid posterior wall, basal anterior septum, mid anterior septum. That becomes an important issue of blood supply. So what we see, 6 segments over here, 6 segments over here, and 4 segments over here. 6, 6, 4. This comes out the 16 segment model, what we see over here. Now this is a pictorial diagram of how my heart is supplied. Look in this. Let's go to 4 chamber, 2 chamber and long axis view. I told you that 4 chamber view, apical septum, apical lateral is supplied by LED. 2 chamber, apical inferior and apical and whole of the anterior wall is supplied by LED. Mid anterior septum and basal anterior septum will be supplied by LED. If I look at this, we have posterior, mid and basal posterior wall, mid and basal lateral wall. Same thing posterior wall seen over here. Mid and basal posterior wall, mid and basal lateral wall. This is circumflex is a territory. And then finally we have mid and basal septum, mid and basal inferior wall supplying the heart, which we call them as RCA territory. RCA territory, the important thing is it may or may not involve RV. If there's a lesion proximal RCA, it will always involve the RV branch. So here's a complete pictures. We talk of LED, which is seen in this picture is LED. All this is supplied by LED. Mid and basal posterior, mid and basal lateral wall, circumflex. Then mid and basal septum, middle basal inferior wall. It's always RC. So we can put in a polar map or a bull-eye shape of pattern. Look, how does the RC supplies mid and basal septum, mid and basal inferior wall, mid and basal lateral, mid and basal posterior wall, this circumflex, rest all supplied by LED. So you have to remember this formulas. How do you remember this formula? Answer is, remembering this formula is, you have to remember somebody who was 60-year-old, anybody who was 60-year-old, 65-year-old. Anybody who's 60-year-old in this picture right now? None. So the answer is, you have to remember like this, mid and basal septum, mid and basal inferior wall, always RCA, RCA, RCA. Mid and basal posterior wall, mid and basal lateral wall, circumflex, circumflex, circumflex. And rest all LED, LED, LED. Some people use 17 segment model, some people use 18 segment model, some people says 19 segment models. And this is the preferred method. You use myocardial opacification to see a contrast in the LV cavity. Look, this is injected into the left arm and right arm, and it bypasses the lungs and come and opacify the LV cavity. That's myocardial contrast. It gives you excellent imaging qualities. 3 dimensions echo, not of your use as on today. The only fact is 3 dimensions echo give you synergy as well as synchronicity. What is mean by synergy? How much these segments are contracting or the ejection fraction is. Synchrony is all these segments they are contracting at the same time or not. That is synchrony. And last is, I would like to say that one important thing which we utilize, we'll try to show you again and again, myocardial performance index of a left side. And I'll put my stop over here and take your questions for my presentation as of today. You can raise your hand. I'll be happy to answer all of you one by one. I'll be sending this video recording to everybody. You can go through it again and again. Because this is few classes, the basic classes are the backbone of these training programs. Dr. Prasha said very aptly, if you'll miss this, you have missed everything. No questions? I know it's difficult to begin with. Believe my words, what I'm going to say is, this course will change you the complete practice. And I give you an answer. Patient comes in shock into the ICU, or your clinic, or a chamber, or a hospital. How do you look at this patient? The first thing we look at is, we look at XHS, we look at an ECG, we look at NT-proBNP, we look at TROP-I. Then everything is fine. Then we go to heart. Look at the IVC, volume deficit. Look at the valves, they are normal functioning. Look at the walls, they are normally functioning. Look at the RV side. If it's dilated, poor progression, poorly contracting, think of something to relation with the chest or pulmonary embolisms. Coronary artery disease, you can look at this 16 segment model, coronary artery disease. If your IVC is normal, everything is normal, then what is answer is? Answer is possibly patient is septicemia. And on top of that, I'm sure many of my colleagues always criticize this answer is, if you have a patient of septicemia, the drug of choice is noradrenaline. If your patient is in a cardiac ischemic shock, noradrenaline is not the drug of choice. It should be milrinone or it should be dopamine dopamine combinations to reduce the preload, not to augment the preloads. All right. So that's what makes a lot of difference when we're talking of these echocardiography. I'll take my question one by one. Dr. Shabir. Dr. Shabir, what is your roll number?
Sir, my roll number is 20, sir.
20. All right, good. Ask me questions, Shabir.
Sir, could you please show me that apical 3-chamber view, sir?
Sure, definitely. 110%.
Thank you, sir.
I'll show the video recording. That'll really help you look at 3-chamber view.
Sure, sir. Thank you.
Apex. And if I hold this probe over here, this will be truly a 3-chamber view. What we have done? We have moved from apex, left parasternal window to apex. Now see it again. I always teach my student how to do it first. Right from here, just slide to left fifth intercostal space. Hold it. This is left third intercostal space. Sorry, 3-chamber view. Now rotate clockwise, it will become 2-chamber view. Rotate further clockwise, it will become 4-chamber view. Now it's doing rotation. 2-chamber, 3-chamber, and 4-chamber. 4, 3, 2. Now hold. This is a true positions for parasternal apical window. So we get 4-chamber over here. Now in counter rotation will happen. 2-chamber. And finally, 3-chamber view. And this 3-chamber view is same as we see in flag swing. All right?
Yes, sir. Thank you so much.
All right, Dr. Kailash, your turn.
Sir, what are the structures seen in the right parasternal view?
Structures seen in right parasternal window.
Yeah,
We
windows.
always focus at aorta,
Okay.
ascending aorta, Kailash. Right
Okay.
parasternal window is most important window is to look for aortic valve gradients.
Okay. Thank you,
If
sir.
I have aortic stenosis, we use 5 windows, rather 6. First window is parasternal. We do not have anything plaques window because aorta would not be parallel. So we see in 5 chamber view, 3-chamber view, subcostal window, right parasternal window, suprasternal window, and right anterior oblique view. Wherever the maximum gradients are, we take those gradients. All right.
Okay. Yeah, sure. Thank you, sir.
Dr. Tushar Agarwal.
Yes, sir. Tushar this side. Sir, my doubt is when we were doing parasternal view, you told that perpendicularly we have to come down to the apical view. But in parasternal, you told we have to keep in the third intercostal space. While if I see the screen in the apical view, the probe doesn't look like it's in the third intercostal. Like how
Tushar,
from
just
third
look at this.
intercostal space we came down. Like it looks
Wait,
like.
wait a minute. Look at this picture again. My probe is left third intercostal space. I'm moving this probe from third intercostal space to apical window. And if I hold this window view over here, I'll be making apical long axis view or 3-chamber view. Once I rotate to clockwise, it will become 2-chamber view. Then rotate, 2-chamber view, rotate further, 4-chamber view. So what is the advantage? This is truly a 4-chamber view. So if I'm in this position, I'm making this 4-chamber view. Then I'm counterclockwise rotating it, I'll be making 2-chamber view. Then I'll be counterclockwise rotating, I'll be making apical 3-chamber view. And look, what is this index marker? It is at 11 o'clock position. Only thing is we are parallel to the heart, as much parallel to the heart as possible.
And sir, any book recommendation, sir, which will be complementary to our lectures? Like we can read that after seeing this
Don't read
lecture.
it. Just go through this lecture as many times as possible.
Okay,
Follow
we'll get.
this. This is practical. We'll send you a book. Book is following you. In
Yes.
next, today's 23rd, you'll start receiving the book on the first week of April, first week of October.
Thank you, sir.
Dr. Rahul Kalita. Rahul. Unmute self, Rahul. Go ahead. Rahul is not seen. Dr. Ajay Chaurasia. Ajay, go ahead.
Sir, as far as books you have advised, that was one of my concerns. So second concern is whether we can get any idea how to use the machines.
We'll come to
There are
knobology.
so many knobs.
We'll come to knobology. We have a live talk on knobology. Just
Okay, sir.
understand
Okay,
these
sir.
views.
Okay, sir.
And in case you
Okay,
want
sir.
to be
Okay.
hurry, in case you want to be very fast,
No,
go
no,
to
no, no.
go to the website, find drop knobology. There's a video on drop knobology. There are 234 videos are there. More than 8 lakh hits are there on these websites. 800,000
Okay, sir.
hits are there.
Okay, sir. Okay, sir.
Dr. Shubham.
Good evening, sir.
Good
My
evening.
question is regarding 16 segments that you explained. With when we are seeing in apical 4-chamber, it is easy to understand that this is septum and that is the lateral wall. But in apical two chamber and three chamber, it is difficult to visualize or imagine the posterior wall and inferior wall. Can you again explain it once more, sir?
110%, as many times as you want without any hesitation, Subham. You should be clear before you go out of this class. I'll just show you again. Why I was asking is how many of you are 60-year-old or not? You know what the answer? At our time, when you used to go to picture hall, the tickets were not available in a routine. You just walk in, buy a ticket, eat a popcorns, coffee, coke, and everything. The ticket used to be sold in black. Do ka char, do ka char, do ka char, do ka char. The same thing you can apply in this training program. How can you apply in this training program is? One of you should say mid basal septum, mid basal inferior wall. First person should say four chamber view, mid basal septum. Second person say two chamber view, mid basal inferior wall. Third person say RCA, 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 RCA. Another group of persons says mid basal lateral wall, mid basal posterior wall, circumflex, circumflex, circumflex. Then in distant voice came rest all LED, 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 LED. Now let me go back and show you what exactly I wanted to tell you. Mid basal septum, mid basal inferior wall, RCA, 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 RCA. Mid basal lateral wall, mid basal posterior wall, circumflex, 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 circumflex. Apical septum, apical lateral wall, apical inferior, whole of anterior wall, apical posterior, median anterior, and apical anterior segments, they are all supplied by LED. In normal circumstances, we do not take apical posterior, apical anterior septum. We only take this mid basal posterior wall, mid basal anterior septum. Now, what is the importance of this? Suppose you go and see a four-chamber view. You see your middle basal septum is hypokinetic, middle basal inferior wall is hypokinetic. So you understand that possibly we are dealing with RCA lesion. And whenever this middle basal inferior wall is involved, this papillary muscle becomes less tensile. So you start developing a mitral regurgitation. Similarly, if you have middle basal posterior, middle basal lateral wall is got a papillary muscles. So even then you find MR, significant MR. And as the time will mature, we'll tell you more ways of looking at these walls. What is the importance of these walls are? So at this present moment, tomorrow morning, go to wherever the bathroom or toilet is. Start calling middle basal septum, middle basal inferior wall, RCA, 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 RCA. Middle basal posterior wall, middle basal lateral wall, circumflex, circumflex, circumflex. Rest all LED, 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 LED. And whenever you see a segmental wall motion notice, your question is right. I can't see two-chamber view. Man, it's very difficult to make two-chamber views. Even today also, I joined doing an echo in 86. 14 plus 25, 39. And still I struggle for making two dimensions view or two-chamber views. But two-chamber view has got papillary muscle. Three-chamber view does not have a papillary muscles. Make sure. So once you see a two-chamber view, you should be one papillary muscle, the other wall should be clean. Sometimes we say a commissural view, where you see both the things like this papillary muscle and this papillary muscle in the same window, which is not correct. So practice will make a perfect, not the lectures. So if you have an access to a machine, just do a normal subject. How did I learn echocardiography? I was working in Jefferson, Philadelphia. What I used to do, I used to give my night coupons to anybody, like technicians. And during the period when I had to learn, the technician used to eat and sleep, and I used to practice on him or her. So take home messages, get a very good room from your spouse, give it to some person who has got a good imaging quality, let him eat your food at 12:30, 1 o'clock, let him snore, you should do an echocardiography. Every day for 30 to 40 minutes. Believe my words, you will become perfect in imaging in very shortly. That's how I used to learn echocardiography. All right, let's move to Dr. Arya. Question, Dr. Arya.